Another common question is, how certain is the pathologist of my diagnosis? There are a couple sort of hints that can tell you how certain we are. And there can be a variety of reasons for why we are certain versus not. So, one of the hints of how certain we are is whether there is just a very clear top line diagnosis, such as basal cell carcinoma, nodular type, present at margins, period, done. Other times we may say something like atypical basaloid neoplasm, present at margins, see comment. And in the comment, we give something called a differential diagnosis. Differential diagnosis has to do with making a list, generally with your most favored diagnosis first. So in that case, it could be the differential diagnosis includes a nodular basal cell carcinoma, period. However, due to some features such as a lack of clefting or myxoid stroma, or the fact that it's been previously biopsied, or the fact that there is additional differentiation within the tumor, such as squamous cell differentiation, or ducts, this can then raise a differential diagnosis of an annexal carcinoma, such as a hidradenocarcinoma. So all of these fancy names, but basically we're saying this is atypical. There's a concern that this is absolutely a carcinoma. And then it's difficult to say what specific type of carcinoma it is. Other times the differential can even include quote unquote benign neoplasms. Sometimes we're not able to say with 100% certainty on a biopsy, especially if it's a partial sample, whether it's malignant versus benign. Additionally, some types of neoplasms that technically are benign, if they have been partially sampled appropriately so, we can't necessarily see the deep edge of the tumor, and so we can't assess for whether it has malignant features, such as whether it's infiltrative, or if there is perineural invasion, or if we see foci of tumor necrosis. So these are some reasons why sometimes there can be a little bit of uncertainty. As I mentioned, it makes a lot of sense for there to be a partial sampling sometimes, because that initial biopsy is not meant to be curative. Generally, it's meant to get a definitive as definitive as possible diagnosis, so that then the clinician can decide the best next steps of how to stage this and or treat it. Another clue that can help give an idea of how certain we are about a diagnosis is whether we give a top line diagnosis that is something we call descriptive. So sometimes we, instead of giving a definitive diagnosis, we'll say, well, probably one that clinicians like the least, and we are very careful about giving, is a psoriasiform spongiotic dermatitis. The reason that can be quite frustrating, and from what I've heard from a provider or a clinician, is because I just said it could be this type of rash or the other type of rash, and they can be managed very differently. The reason that this sometimes is required, though, is because there can be those mixed features. Some factors that will contribute to these mixed features will be if it has been previously treated. For example, if there has been consistent topical steroid use, perhaps if there have been other topical therapies, and then sometimes as well if there has been even endogenous steroid, if the patient is on steroids for other reasons or medications for other comorbidities, that can also sometimes confuse the histologic picture. Another example this may occur in is when someone is suspecting a dermal hypersensitivity reaction, and if understandably due to the severity of it, the patient has been put on steroids, sometimes that will cause there to be fewer diagnostic inflammatory cells under the microscope. Another example that can cause some diagnostic confusion in an already notoriously challenging diagnosis involves mycosis fungoides. So if someone has a rash in a bathing suit or trunk distribution, and it has been biopsied and under the scope it looks like this could be an inflammatory condition, some of the things we look for in particular involve lymphocytes along the dermal epidermal junction and or lymphocytes showing epidermotropism, or if it's not malignant, then we call it exocytosis into the epidermis. One of the things that can be, I'm sure, frustrating from a clinical standpoint is that we will get a biopsy of rule out mycosis fungoides, but if the patient has been on steroids, particularly topical steroids within the past 4 weeks, that can tamp down the lymphocytic exocytosis and junctional tagging. And so that actually reduces the number of diagnostic factors that we can reasonably look for. And so sometimes there'll be a comment that